Well, welcome to the Glaucoma Rapid Fire session. So we have a lot of really interesting talks here on the program, I see. So hopefully all our speakers are here. They're short talks and we must be very strict on the timing. So you'll have 5 minutes to talk and then 1 minute questions. So if you go over the 5 minutes, we'll just have to stop you, I'm afraid. So perhaps if, I think we could probably get you starting now then. So we have Mazuro Inatani as our first speaker, talking about intraocular pressure lowering effect of intraocular lens refixation. All right, thanks for that.
Hello, good afternoon, namaste. My name is Masaru Inatani from University of Fukui, Japan. Today's my talk is IOP lowering effect of intraocular lens refixation in patients with elevated IOP due to IOL subluxation. Previous studies reported an association between IOL subluxation and IOP elevation. However, the mechanism still remains unclear. It doesn't work. So IOL refixation combined with glaucoma surgery effectively reduces the elevated IOP in patients with IOL subluxation. Some clinical studies suggest that refixation of the subluxed IOL alone also decreases the elevated IOP, although the maximum sample size in the previous reports was very small. Therefore, it remains unclear whether refixation of the subluxed IOL alone is effective or not. The purpose is to evaluate the surgical outcomes of IOL refixation alone without glaucoma surgery in patients with elevated IOP due to IOL subluxation. Patients with IOP elevation and a subluxed IOL who were treated with IOL refixation and vitrectomy were analyzed. Each patient underwent a 25-gauge pars plana vitrectomy. After the removal of the subluxed IOL, a new IOL was fixed into the sulcus. Primary outcomes were surgical successes based on the postoperative IOP levels, as shown in this slide. We divided the patients into the glaucoma group or ocular hypertension group. The glaucoma group consists of patients whose eyes had originally been treated for glaucoma. The OH group consists of patients without glaucoma optic neuropathy who developed IOP elevation after IOL subluxation. The slide shows patients' background. In total, 24 patients were recruited. A glaucoma group had 13 patients. The OH group had 11 patients. The glaucoma group was significantly older than that of those in the OH group. The most common prevalent glaucoma subtype was exfoliation glaucoma. The slide shows the Kaplan-Meier analysis of the surgical outcomes. So as you can see, the probable success in 1 year was 73% in criterion A, 54% in criterion B, and 28% in criterion C. The mean IOP significantly decreased from 30 mm mercury to 16 mm mercury. The medication number, glaucoma medication number, significantly decreased from 2.7 to 1.8. We compared the surgical success between the two groups. As you can see, in criterion A, the probability of success in the OH group was 100%. On the other hand, the probability of success in the glaucoma group was 47%. So the success in the OH group was significantly higher than that in the glaucoma group in criterion A. The slide shows the IOP levels and glaucoma medication numbers before and after surgery. So as you can see, both groups showed the reduction of IOP levels and glaucoma medication numbers after surgery. However, the glaucoma group were treated with about 3 glaucoma medications even after surgery. There was no significant difference in the postoperative complications between the two groups. Additional glaucoma surgery was required in 4 eyes, and all of them belonged to the glaucoma group. IOL refixation alone improves the IOP control. The success outcome in the OH group is significantly better than that in the glaucoma group. In the OH group, IOL refixation normalizes IOP elevation. Additional glaucoma surgery is required in the glaucoma group because the aqueous outflow facility is originally impaired in the glaucoma eyes. The aqueous outflow is not completely recovered after IOL refixation. Limitations are due to retrospective single-center study, relatively small sample size. Conclusions: IOP refixation significantly decreases IOP and glaucoma medication number in patients with elevated IOP due to IOL subluxation. IOL refixation alone without glaucoma surgery is effective for IOP reduction as a primary procedure in such patients. Thank you for attention.
Thanks very much. Thanks very much. One quick question? Yes.
Can you explain the mechanism by which IOP is getting reduced after the IOL refixation?
Sorry?
What is the mechanism of IOP?
Mechanism? So probably, so IOP, so IOL subluxation causes friction on the iris. So iris pigmentation occlude the trabecular meshwork. It's the one reason. Another reason is inflammation. So inflammatory cytokines causes the damage of trabecular meshwork, probably.
All these had glaucoma due to the IOL, not
Yes.
pre-existing
Yes.
glaucoma.
So in glaucoma patients, so IOP becomes worsened, to be worsened after IOL subluxation. But ocular hypertension group occurred because of IOP subluxation only.
Thanks very much. Thank you.
Thank you.
Thanks for the talk.
Our next speaker is Zifeng Yang, and he will be speaking on digital gonioscopy based on three-dimensional anterior segment OCT. Zifeng Yang. Okay.
Hello everyone, I'm
Is he saying
Zhe
not
Yang from Zhongshan Ophthalmic Center. It's my pleasure to be here to
good.
present our study titled Digital Gonioscopy based on three-dimensional anterior segment OCT, an international multi-center study. Before we begin, I would like to disclose that I do not have any financial disclosure. Let me introduce the prevalence and the natural history of angle closures at first. Angle closures affect more than 70 million people worldwide. It is a huge burden, particularly in Asia. The spectrums of primary angle closure disease include primary angle closure suspect, PACS, primary angle closure, PAC, and primary angle closure glaucoma, PACG. Timely identifications of patients with PACD may allow for early treatment to prevent vision loss. Today, there are several clinical techniques for detecting angle closure, including gonioscopy, SOCT, UBN. Gonioscopy is the reference standard. SOCT is a non-contact, rapid, and high-resolution tool. UBN is a real-time, interference-free source for us. But here is the problem. The newer technique, particular gonioscopy, faces several challenges. It is subjective. It has poor agreement, both between and within observers. It is difficult for non-glaucoma specialists to master gonioscopy examination. There is a long learning curve involved, and the light sources and the lens placement can introduce variability. With the development of AIOS0225, it offers a powerful imaging solution with the advantage of non-contact, rapid, and high resolution, but it lacks the ability to detect the angle dynamically. Here, our study aimed to develop a deep learning-based automated digital gonioscopy, DGS, using 3D ASOCT. We had two main objects. Task 1, narrow angle detection. Task 2, peripheral and anterior synechral detections under dynamic condition. The symptom can be divided into static DGS, performed in the dark room, and dynamic DGS, performed in both dark and light conditions. This study was designed as an international, cross-sectional, multi-center study. We include a total of more than 8,000 volume scans across 3 centers. For text 1, about 4,000 scans were used for training, 1,000 for internal validation, and 2,000 for external validation. For text 2, 378 scans were used for training, 376 for internal validation, and 100 for external testing. The ground truth label is based on gonioscopy record. In text 1, for external validation, 3D DGS achieved the diagnostic performance close to that of ophthalmologists in angle closure detection. Both sensitivity and specificity was above 80%, demonstrate the symptom's high accuracy in detecting angle closures. In text 2, for external validation, 3D DGS is the first deep learning covering both static and dynamic gonioscopy and detections of PAS based on AIOS0225. The AUC was 0.902. Both sensitivity and specificities were above 90%, demonstrate the symptom's high accuracy in detecting PAS. At the clock hour level, this value was slightly lower, but still robust, showing the potential for accurate detection. Here you can see the heat map generated by 3D DGS symptom. The 3D DGS diagnoses the angle closures based on the structure close to the anterior chamber angle. The 3D DGS detected the PAS by comparing the morphological change of the iris adjacent to the iris-corner angle, mainly the iris root and the middle part of the iris. In summary, we have developed a reliable DGS that not only could differentiate narrow iris corneal angle, but also could determine the location and range of PAS in angle closure suspect patients. Our CDDGS is effective in detecting eye with suspected PACG. It has the potential to be used widely in primary eye care community for screening the subject at high risk of developing PACG. Future directions include validating the algorithm in diverse populations, testing it with images from different OCT devices, and improving its ability to detect point synechia and classify the narrow angle in different grades. This research was published in the Ophthalmology. I would like to express my gratitude to all the collaborators who contribute to this study. Thank you for your attention.
Thanks, Zifeng. We'll go straight to our next speaker. No time for questions there. So next speaker is Eric Jin. Thanks, Eric.
Good afternoon, ladies and gentlemen. I'm Eric Jin, a final year medical student from the National University of Singapore. And today I'll be presenting our study, aqueous humors outflow assessment using imaging-based techniques in angle-based mix, a systematic review. Glaucoma is the leading cause of irreversible vision loss worldwide. Angle-based mix has emerged as a safer and effective alternative to traditional glaucoma surgeries by targeting the conventional outflow pathway and bypassing the trabecular mesh resistance. However, despite improvements in surgical technique and implant design, its outcomes remain limited by factors such as episcleral venous pressure flow, distal outflow resistance, and variabilities in aqueous humor outflow. Recent advances in ophthalmic imaging, including anterior segment OCT angiography, fluorescein angiography, and hemoglobin venous imaging, offer promising opportunities to assess aqueous outflow pathways and improve surgical planning and outcomes. As such, our study aims to systematically review the existing literature on the use of imaging-based techniques to visualize aqueous human outflow pathways at all 3 stages of surgery, including pre, intra, and post-operatively. We conducted a comprehensive literature search looking for English studies examining imaging techniques in angle-based MIGS up to February 2025. 26 studies were finally included in our study, which included 685 patients and 27 enucleated eyes. The most common imaging techniques used were direct observation of the episcleral vein, as well as fluorescein with ICG aqueous angiography. Preoperatively, AIOS0225 studies suggested that lower preoperative deep vessel density may predict greater postoperative IOP reduction. However, superficial vessel density did not correlate significantly. Intraoperative ICG aqueous angiography was able to map out the aqueous humus outflow network pre-mix implantation and identify areas with initial low or high flow, allowing for potential targeted placement of mix. However, while some studies found benefit in targeting angiographically low flow regions, others have shown faster recovery when targeting high flow areas. Observation of the episcleral venous fluid wave intraoperatively also found that both the extent and area of fluid wave positively correlated with IOP lowering efficacy. Intraoperative techniques such as fluorescein angiography and trypan blue injection also provided real-time confirmation of outflow pathway patency, potentially enabling immediate surgical adjustments. Postoperatively, hemoglobin venous imaging allowed for the objective assessment of restoration of the outflow pathway. Observation of the episcleral venous outflow also found that higher grade correlated with better surgical outcomes and could serve as objective surrogate measures beyond clinical IOP readings. AIOS0225 studies also found that greater deep vessel density reduction after surgery was correlated with greater degree of IOP reduction. Significant reduction in deep vessel density was also only observed in areas with stent implantation. These findings have several important clinical implications. Firstly, although ICG aqueous angiography studies are conflicting whether we should target initial low or high flow areas, these important studies have helped us to establish a better understanding of functional anatomy relevant to angle-based MIGS. Future studies are likely to leverage on these protocols and methods in their further exploration of the correlation between angle-based surgeries and angiographic signals. Secondly, quantifiable preoperative and intraoperative metrics help to predict preoperative success. Thirdly, intraoperative imaging may help to guide intraoperative decisions to modify and adjust intraoperative techniques based on the restoration of the aqueous human outflow. Finally, post-operative imaging techniques may provide objective measures of aqueous human outflow patency and surgical success. However, despite these promising results, several barriers exist. Firstly, technical challenges in imaging remain, particularly with resolution and artifact management in imaging such as AIOS0225. Secondly, the impact of IOP lowering medication provides potential confounding variables in vessel density measurements. Thirdly, the field suffers from limited large-scale studies with more evidence coming from case series and case studies. Fourthly, there's a notable lack of standardization in protocols across institutions, limiting the comparison of effectiveness across protocols and approaches. And lastly, cost and time constraints pose significant challenges to widespread implementation. In conclusion, imaging techniques for assessing aqueous human outflow show promise for enhancing angle-based mixed outcomes, though larger studies with standardized protocols are needed to compare between the protocols, resolve conflicting findings, and establish clinical guidelines. And I'd like to extend my gratitude to my mentor, Professor Brian Ang, for his valuable guidance throughout the project. Thank you.
Thank you. I guess we don't have a time for question. You can talk to the speaker afterwards. And should we go to the next speaker? That's Jingwen Jiang. Is that also mine? Jingwen Jiang. Is Jingwen Jiang around?
Jingwen Jian? Jingwen here?
Not present? Okay. In that case, we will have a question, I guess, in that case, yeah. So, Eric, would you, does anybody have a question for Eric? Good. Save some time, right?
Well, we've made up some time, so we'll go to the next speaker.
Yeah, I think we should go to the next speaker. And then we have, would you like to introduce the speaker? Yeah. We have Tayyaba Malik next. Yes, not present. Good.
Okay. We're making
Now
up
we
a
have
lot of
enough
time
of
here. We're going
time.
to have some time for discussion. That'll be
Yeah,
good.
yeah.
Taiba Malik is not here?
Is Taiba Malik presenting online or something? No? Okay.
Chuk Kai Huang?
Not present?
Not
Okay.
present.
Okay.
Up to you, Monib, then.
Oh, wow.
We haven't... In which
I
case, we're up to
bypassed everyone.
my co-chair has got a really excellent talk for us, and we've got heaps of time for discussion.
Okay.
Okay. Manib.
Let's start from there.
Yeah.
I'll be talking about the functional characterization of some of the mutations, the novel mutations that we had found in our patients here in our population in India. I don't have any conflict of interest. So the study comes from actually some of the previous papers in which we scanned the PCG patients in North India, and we found a lot of mutations, and 7 of them were novel, and out of 7 we excluded 3 because one of them was synonymous and one was truncating, and one patient had a mutation in the LTBP2 gene as well. So the idea was to see one gene, that CYP1B1 gene, since PCG has a trabecular meshwork isolated anatomical anomaly of trabecular meshwork dysgenesis, we thought, okay, let's have a CYP1B1 gene and see how it might lead to trabecular meshwork dysgenesis. So we chose these 4 mutations. Initially, we did polyphenol SIFT analysis. These are some in silico tools, some basic tools which tell us about the pathogenicity of a mutation, probable pathogenicity of the mutation. They do some kind of scoring, and you'll see that these 4 mutations, L24R, F90L, H279D, and G329D, had different pathogenicity based on these scores. And then we started trying to map the mutations, and we found that this MT1 was in the signal peptide, and this MT2, MT3, and MT4 were in regions which were actually helical regions, and they formed a triad. And you would also see that these mutations, these places, the positions of these mutations are actually evolutionarily conserved, so they might be functionally important to the protein. So what we did is, we did structural modeling using modeler, and then from there did energy minimization, chose top 10 best structures using ProCheck, verified 3D, GrowMax, HP+, Pocket. These are different programs trying to look into different types of structural parameters, and then from then we chose one top structure using the Ramachandran curve, and then visualized with PyMol and Python. To give you just a rough idea how the mutations compare, the green one is the wild type, and this is mutant 1, and the surface area that you see is actually the mutation point. For MT2, you see there's a drift. For MT3, you see there's even more change in the mutation area and the structure of the protein, and MT4 also there is a lot of change. So after that, we thought, let's look into the various pathways that CYP1B1 plays role in, and we checked the literature using these tools, online tools, and we came up with 166 metabolic processes. And then we went on to sort them out on the basis of their functionality in the eye development. 36 processes were there, and they were sorted into types of pathways, and these pathways were estradiol metabolism, retinol metabolism, melatonin metabolism, and arachidonic acid metabolism. So we, after that, thought, let's subject the protein product of these mutations to functional assays. We express the protein. On the left, you would see that there is the expression of the protein, heterologous protein, and on the right, there's purification. So we expressed the protein, purified it, and subjected it to first to see if the expressed protein is stable. We saw that there was a decrease in stability in silico as well as in vitro, and the stability decreased with MT4 and MT3 having high, loss of stability at many different temperatures. And we compared the enzymatic assays with the estradiol metabolism. There was loss in all the mutants, with more profound loss in MT3, MT4, same in retinoid metabolism, arachidonic metabolism, and melatonin metabolism. So taking all this together, so CYP1 mutations actually, with regards to estradiol metabolism, leads to myocilin upregulation, which leads to thickening of the trabecular meshwork bands and increased intraocular pressure. and other PCG symptoms. And retinoid metabolism leads to estrogen receptor loss, again, estradiol metabolism and downstream. And retinal toxicity as well, which leads to photophobia, and arachidonic acid metabolism leads to inflammation. Inflammation leads to change in the extracellular matrix and trabecular meshwork thickening, and melatonin metabolism, estrogen receptors, again, oxidative stress, which leads to extracellular matrix change and thickening of the trabecular meshwork beams, and PCG. So we conclude that these 4 metabolic pathways might be the mechanism underlying CYP1B1 mutations and PCG. There we go.
That is a super talk, Manib. That could have been a 30-minute talk. That is a lot of, that is years of work there, a lot of stuff. Questions for Manib? I do. Have you got any druggable targets there, Manib, for treatment?
Oh yes, arachidonic acid metabolism we can target using anti-inflammatories. And particularly with regards to the retinoic acid metabolism, I think the retinoic acid response elements in the genes can be targeted using drugs. So yes, I think we are working on that as well, if that was your question.
Yeah, I mean, and would they potentially be targets even in POAG? Some of the stuff you've found there?
I would love to say yes, but I need to have evidence from literature. I assume that is the case, yeah.
Okay. Any other questions?
We have time for questions if
Manib?
anybody has.
What does estradiol do in just the ordinary trabecular meshwork? What's the role of estrogen in the trabecular meshwork?
So I think the story starts from seeing higher propensity of glaucoma in postmenopausal women,
Yeah.
in which the estradiol actually has a role to play in the hormonal change, and it was found that estradiol, 4-hydroxyestradiol, is being hydroxylated at the 4 position using CYP1B1 through myosin. So it binds up stream at the CYP1B1 expression region. So higher expression of CYP1B1 lowers myosin. So if you have loss of the CYP1B1 function, myosin gene goes up. Myosin has a role to play in maintaining the trabecular meshwork beams. So if you have upregulation of myosin, so that's the trabecular meshwork inducible glucocorticoid receptor, it leads to thickened beams, lesser pore size, resistance to outflow. There you have the disease.
Okay, great. All right. Well, thanks, Manib. Looks like there's no more questions, but super talk. Thank you very much. So, next on our speaker list is Rahimi. Is Rahimi here? Yes, fantastic. Okay.
Okay, good afternoon, everyone. My name is Rahimi from University of Science Malaysia. Today, I would like to present my latest study titled The Effect of Lifestyle Habits and Risk of Glaucoma, specifically on cigarette smoking and physical activities. Okay, first of all, I have no conflict of interest.
Wow, really good. Wow.
So glaucoma is a chronic progressive optic neuropathy characterized by structural and functional changes. These are well-established, identified risk factor for primary glaucoma. And however, there is minimal studies done among the Malay population. Malay population account about 5% of world population distribute in Southeast Asia. Thus, it is important for us to identify the risk factor among the Malay population. Thus, with that, our objective is to determine the association of cigarette smoking and physical activity as a risk factor for primary glaucoma in Malays. So this is a post hoc study based on the Malay Glaucoma Eye Study database. From that, we identified about 750 samples from the primary glaucoma. These are the inclusion criteria, and this is the exclusion criteria for the sample. And for control, we've total 250. These are the inclusion criteria. And this is the exclusion criteria. So from that database, we use, for cigarette smoking, we use Singapore Malay Eye Study questionnaire and divide into active, passive, and non-smoker. And then for the physical activity, we use the IPAQ, International Physical Activity Questionnaire, and divide that into the sedentary, mild, moderate, heavy, based on the frequency and duration of activity, as well as metabolic equivalent calculation. So from that database, we use the multiple linear regression for the data analysis. And then as the result, these are our demographic data. From this table, we can see the primary glaucoma significantly more common in low education level group. These are the distribution of smoking status and physical activity level. So from these are the multiple logistic regression. From this table, we can identify that women have higher risk of developing glaucoma in Malays. Every increase of 1 year of age increase risk of glaucoma by 1.06. And active physical activity significantly will reduce the risk of glaucoma. Finally, non-smoking significantly reduce the risk of glaucoma. So from this study, we can identify these fellow risk factors: smoking, low physical activity, low education level and age. But somehow we able to identify some limitations, such as this post-hoc study will automatically have some bias. And also 3-to-1 sample to control ratio will also have potential bias. And this study itself based on the questionnaire. So for the age and low education level, there are no doubt because these are well-established risk factors done in many various studies. And also physical activity also was supported by a previous study by Al Salim and Niven in 2017. And smoking, there are some meta-analysis by Zhou Wai et al. In 2016 that suggests that no association between smoking and glaucoma. So for the conclusion, cigarette smoking and physical inactivity are potential risk factors of glaucoma among Malays. Thus, it is recommended to change the lifestyles of those with other risk factors of glaucoma. And these are my reference, and thank you for listening.
Thanks for that. Any questions? Yes, please.
Oh yeah, for low education level, from previous study, they state that low education is related to low awareness of the disease itself. So they come late to the hospital and late treatment received. So they tend to have some advanced glaucoma status.
Can I have a question? I have a question, which is actually the own question. One is, how did you quantify the physical activity? How did you measure the amount of physical activity? What methods did you use to quantify what amount of physical activity? How did you decide a person is active or not active? And following that, physical activity leads to lower blood pressure. And low blood pressure is a risk factor for glaucoma, right? So how do you reconcile the two?
For physical activity, in this study, we use International Physical Activity Questionnaire. In that questionnaire, they divide into mild, moderate, and heavy activities based on the metabolic equivalent calculation. And then they only divide into that.
Yep. Thank you.
Thank you.
One more quick. With female gender as a risk factor, was that for both open angle and angle closure glaucoma combined, or for both types of glaucoma?
Oh, yeah.
Or just angle closure?
Yeah. From this study, we combine primary open angle and closed angle. And for the conclusion, based on the previous study, they conclude that women tend to have higher risk factor compared to male due to they have lower physical activity rate compared to the male.
Okay. Okay. Thank you.
Ah, great.
Okay.
Now we have Difu Chen as the next speaker. Can we have Difu Chen? No? Okay. Your turn.
Difu Chen, not here? Okay. Speaker number 10 then we have on our list is Yuan Bo Liang. Yuan Bo Liang, not here? Not here? Okay. Try Zhao.
Oh yeah, you can go next.
Zhao Yi Lu?
Yeah.
We're going to finish early here.
Wow.
Zhao Yi Lu's not here? No? Okay.
We thought we'd be running out of
Then
time.
the next, Yuan Bo Liang was on again, so no. Apano Rao.
Aparna Rao, is she here?
Apano Rao is not here. We are done. Do you think she's not here? You think?
Aparna Rao, is she here?
Does
Okay.
Apano Rao have the slides up? Are the slides loaded for Apano Rao? No.
Okay, then we're done.
Okay.
So yeah,
Any questions for any of the speakers that were here? We can have a little.
yeah, we can have a
discussion.
little discussion.
So you have no more slides loaded for any speakers that we haven't heard from?
For whom?
For
Aparna. Okay.
the slides are loaded.
Okay. So what do? We run through the slides or something?
Do we know if is it she?
Yeah, it
Is
should be
she.
she.
Is
yeah.
she at the meeting? She's here.
Okay.
Can we get her? Can we get her? Can we bring her back? Bring her back.
Can we bring her back?
Let's bring her back. She's on. Let's bring her back right
Maybe
now.
she thought that there will be time. Yeah, she still has time.
Any questions for any of our speakers?
You want me to present again?
Let's just see if we can bring her in then. Is someone going to find her?
Yeah, I think
They have?
this gentleman went out.
Is this Apano? No. In which case, we'll wrap apparently Apano Rao is not here, so we'll wrap the session up. Well,
Okay,
sharp and
thank
shiny
you for your
session.
presence.
Thank you very much to our speakers, and thanks to all of you for coming along. Thanks very much.
Yep, thank you.